thank you very much for being here and for accepting my invitation to be the first speaker in this first webinar of the new series webinar of the technical community on therapeutic and diagnostic system and technology. Today we have the honor to have Professor Danilo Pani that will talk about fetal diagnosis and monitoring technologies, historical perspective, and modern innovation. First of all, let me introduce our speaker. Danilo Pani is an associate professor of biomedical engineering at the University of Cagliari, Italy, where he also serves as a coordinator of the bachelor and master programs in biomedical engineering and head of the medical devices and signal processing lab. He teaches biomedical signal analysis and processing as well as biomedical instrumentation. His research focuses on medical devices, biomedical signal processing, and machine learning, with particular emphasis on cardiac electrophysiology and non-invasive fetal ECG, wearable electronics, unconventional electrodes for electrophysiological signal monitoring, digital biomarkers in neurophysiology, neuromotor telerehabilitation, and Professor Pani is author of more than 150 indexed publications in journal, books, and conference proceedings and holds 6 patents. Over the years, he has developed a strong international research network, particularly in the fetal electrocardiography and fetal monitoring, and has organized several related scientific events in Sardinia and Italy. So thank you very much. And if you want to start, Danilo, whenever you're ready, please feel free to share your screen and the floor is yours.
Yeah, thank you very much. I'm trying to share now.
Okay.
Okay. Sorry, I was kicked off the meeting. I don't know why.
Okay. Okay. Let's
Um,
try now.
okay. Let me share the screen. And you should be now able to see.
Yeah, maybe a couple of seconds. Yeah, perfect. So we can hear you. We can see
Okay.
your screen. Yeah. So feel
Okay.
free to start whenever you're ready.
Perfect. So just a moment to have back the control of the presentation. And here we are. So, thank you again for the introduction. It's really a pleasure for me to be here and to present this talk about fetal diagnosis and monitoring technologies. Also because this one was one of my first research topics in my academic career, in particular fetal ECG processing. So you already introduced me, and so I don't want to repeat anything about this. In this slide, you can find some reference to my lab and a nice picture, not really perfectly up to date of my group, of my research group. Of course, just a quick intros of my lab. I come from Italy. University of Cagliari was a quite old university, established over 400 years ago. Cagliari is the capital of Sardinia, which is the second big island of Italy in the Mediterranean Sea. It's a nice seaside place. If you would like to come for a visit, I would be very happy to to host you. And of course, Sardinia is also maybe known for its nature and sea, but for sure the main attraction is the MediaSP lab of my group, which is focused on biomedical engineering And the topic, among the topics that we deal with, there is fetal electrocardiography, which is one of the fetal monitoring techniques. And this gave me the opportunity to work with different scientists in the field and to produce several of my research papers. Starting from the original seminal works that I did by developing real-time independent component analysis techniques, implementing also them in real time on embedded system hardware, and also collecting a data set that is now freely available on the internet, which is the NIMFEA data set, and working also on other signals such as Doppler ultrasound signal. With colleagues that now work in the field here in this picture, it is possible to see Eleonora Sulas that now works in Bloom Life Technologies, and other colleagues that over the time continue that work also in companies. This gave me the opportunity to organize also two summer schools in Sardinia in 2018 and 2021. That also led to two interesting books on innovative technologies and signal processing in perinatal medicine. So if some people are interested in these kind of topics, they could find in this book some references. And also in 2024, I hosted in Cagliari with Antonia Georgieva the signal processing and monitoring in labor workshop that this year will be in Oxford again, hosted by Antonia Georgieva and Mariana Tomé from University of Oxford and by me. So if anybody is interested in this kind of topics, please feel free to contact me. So it's time to start with the talk, with the technical part of the talk. So why fetal monitoring? Fetal monitoring is related to the monitoring of the baby during pregnancy. In pregnancy is a beautiful but dangerous period for the baby. And so it's important to somehow be sure that the fetal well-being is preserved across the pregnancy. Fetal well-being is challenged by several conditions, also depending on the period. Just to cite a few of them, complicated births that leads to fetal distress, perinatal asphyxia, and the consequences that are mainly in the neurodevelopmental deficit and serious damages of the brain of the baby. Preterm births that are more than 1 in 10 babies, according to the World Health Organization, that caused, for instance, some years ago, almost 1 million deaths of the children under 5 years of age. And other conditions such as the intrauterine growth restriction, which is a pathological slowdown in the fetal growth pace that results in a fetus that is very small compared to the fetuses of the similar gestational age, and then to very small newborns. And this is also a critical condition for the baby that can be monitored during pregnancy, not only by conventional ultrasound techniques, but also by other more unconventional methods. So, as I said, pregnancy is a critical period, and so from the perspective of the engineers, it is possible to contribute by developing devices. And with devices, I mean sensors and machines, but also software algorithms and artificial intelligence tools that are needed for the emphasis of the information that is contained in the signals, but also for the development of prediction algorithms that are able to somehow quantify the risk, for instance, of a given condition for the baby. So just taking some key points that one of the most important, probably the most important scientist on fetal monitoring, which is Professor Gary Clifford from the Emory University, mentioned in one of his talks. Fetal monitoring is cumbersome for different reasons. First of all, the signals are weak and difficultly accessible. they involve more than one person, the measurements, because there is the baby and the mother, and this can be at least two, because if there are twins, they can be even more than two people involved. And this is a problem because they share the same physical space and the signals affect each other. So it is really a critical condition that too. Data collection is difficult. It's difficult to have big data sets, and this is a limiting factor also for the development of the technique, signal processing techniques, because there is a lack of data. Consequences of being wrong are severe because sometimes you perform fetal monitoring because you want to assess the well-being of the baby during pregnancy or during labor. And if a misdetection of a critical condition comes, then you can have really bad outcomes for the baby up to the death. Of course, this is even worse if the gestational age is reduced, because in that case, the fetus is also not completely formed, and then there are also difficulties because of that reason. So, fetal monitoring technologies can be considered from technological perspectives according to the different sensors they are using, or to the different um, apparatus they are trying to monitor and to measure. So the first fetal monitoring technology for sure was the auscultation, intermittent auscultation of the fetal heartbeat by the pinard stethoscope. But of course, the auscultation can be performed in a different way by 1D ultrasound technologies that can also extend to 2D ultrasound technologies to have some morphological information, even with handheld devices. Another important technology is fetal ECG. In this case, you see an invasive fetal ECG machine, but there is also the possibility now to collect non-invasive fetal ECG by applying electrodes on the maternal belly, as we will see in a while. Multimodal measurements, so recording of ECG, phonocardiogram, 1D ultrasound, Doppler, etc., can be useful for low, medium income countries where conventional and more sophisticated technological assets are not available. In European and USA, Canada, Asia, medium high income countries, conventional labor monitoring is performed by cardiotocography, so CTG, and by conventional ultrasound machines. However, there are some facilities like the ones that you see in this picture for magnetocardiography, fetal magnetocardiography, or even fetal magnetoencephalography. So, very advanced techniques that are aimed to study the signals from the baby, trying to remove the interferences based on the physical approach to the recording. Other signals are also the signals from the uterus, so the uterine contraction, but also the electrohysterography, which is the electrical signals produced by the uterine contractions. So, according to more or less almost arbitrary ranking of these technologies in the clinical practice, as you can see, the first one for sure is the conventional ultrasound, which is used for morphological analysis of the baby, echocardiography, etc. The cardiotocography, which is mainly used in labor, and invasive fetal electrocardiography, which is also sometimes accompanied by non-invasive fetal ECG devices that are gaining some space also in the clinical practice. So let's start this journey with fetal auscultation. Fetal auscultation is of course the oldest technique. In 1883, Kennedy started discussing the fact that head compression produced bradycardia, and this reflected in the slow return to the baseline after uterine contraction that produced the decelerations. And 10 years later, vehicle established the limits that are currently used also for the detection of fetal distress, which is an uncommon complication of labor that says that the baby is not well and typically because of low oxygen levels in the brain. Fetal heart rate is relevant, of course, not only because it says that the fetal heart is beating, which is already something interesting, but also because the modulation of the fetal heart rate is managed by the combined interaction of parasympathetic and sympathetic nervous system that, roughly speaking, operate in antithetic way. So the sympathetic nervous system has an effect aiming to increase heart rate principally, and parasympathetic operates in the opposite way. So it's the balance between these two systems that creates what we say a sympathovagal balance. That is the way that fetal heart rate is controlled by the autonomous nervous system. And a proper response of the fetal heart rate, depending on the different stressful conditions that could happen, for instance, during pregnancy, but all the more so during labor, is important because if the baby is not responding correctly, this means so the heart rate does not change, for instance, according to conditions such as strong uterine contractions, etc. It means that the baby is in distress, so it's not able to cope with this external condition and must be removed by C-section, okay, from the abdomen in order to preserve his or her life. Um, so the adjustment of the fetal heart rate is very minute, and it continuously work in order to keep the baby on track as an autonomous vehicle in this picture. But during labor, these conditions, so deceleration and acceleration, can be more strong. And then it's their analysis that enables the obstetricians or gynecologists to detect abnormalities that can be considered prognostic features for instance, fetal distress, acidemia, and so on. So, beyond the fetal heart rate, from the analysis of the sound of the heart, it is possible to detect other important characteristics. In this case, we consider not the intermittent auscultation of the fetal heart, but what we call phonocardiography. So, phonocardiography is the recording of the heart sound, also from an adult patient. But on the baby, again, it is more difficult because there are also interfering sounds from the mother. This, according to the principal signal processing techniques that work in this kind of conditions where multiple sources operate in parallel, led the researchers to develop signal systems where you have multiple sensors, so multiple microphones arranged in arrays in order to exploit, for instance, blind source separation techniques to extract the meaningful signal from the baby. So the phonocardiography is capable of detecting some additional features compared to the fetal heart rate, such as the opening and closing of valves, turbulent blood flow, or other problems that are associated with congenital heart diseases. From the sensor's perspective, it is a set or a single microphone, so nothing more, arranged in a bell-shaped stethoscope. The issue is that of removing the interferences that are present, but the information that the phonocardiogram can provide are interesting. In this picture, you can see S1, S2 tones that are related to the closing of the valves that isolate atria from ventricles in the first case, so S1, and that close the flow to the blood in the ventricles from the pulmonary and aorta arteria. According to this technology, it is possible to study also this kind of sense of signals that can be useful to detect abnormalities in the opening and closing of valves. regurgitations, and so on. On the babies, it's also possible to look at signals such as S3 and S4, which are the protodiastolic and the presystolic signals that are uncommon in odors. So, in odors, for instance, the presence of S4 and S3 is associated to split rhythms such as gallop rhythms that, however, in the babies are quite normal. For these signals, the cutoff frequency is typical between 20 and 100 Hz normally, or up to 800 Hz in terms of the low pass filter to be able to detect heart murmurs. Uh, According to the heart rate of the baby and to the size of the heart, during pregnancy, the spectrum of this signal changes. In this picture, you can see clearly the spectrum of the mother, which is this first peak that is strict at a lower frequency compared to the other, which are related to the baby. And this is because during pregnancy, the baby growth and the heart rhythm decreases until the baby is born and the heartbeat decreases even more. And so you can see that according to the gestational week, the larger the gestational week, the strict the bell-shaped waveform representing the spectrum of the PCG signal. There are also technologies based on optic fibers that have been proposed in order to overcome some limitations of conventional methods, such as providing electromagnetic interference immunity and providing information similar to the cardiotocography, but without the use of ultrasound energy that must be delivered to the fetus in those cases. So these are technologies that are commonly not used in clinical practice, but are research technologies that can be further evolved in effective clinical devices. The clinical adoption of phonocardiography is limited. Only 8 commercial devices, at the best of my knowledge, exist, and their clinical adoption is limited. Some studies demonstrated that, however, this technology performs quite well compared to ultrasound-based cardiotocography, but this is not sufficient to have a widespread adoption of this technology in the clinical practice. An alternative solution is that of using 1D ultrasound, Doppler ultrasound. So in this case, the system is based on an ultrasound probe, and the 1D signal is used to detect the movement of the heart walls of the baby. So the same principle can be used in different devices with different costs, starting from very low-cost devices that are suitable for low-medium income countries, where maybe devices more complicated are unavailable or will be unaffordable. Um, the signal that we have is quite good and is clearly able to detect the heart rate of the baby. The pros of this solution is that it is less sensitive to external interferences and does not need multiple probes. The cons is that it is an active measurement, so it is not suited for long-term monitoring because it delivers energy to the baby. The signal that you obtain, that you can see here in this slide, so in the lower part of of the plot, is quite similar to the one that you can achieve with, for instance, a phonocardiographic signal, in this case acquired with fiber optic sensors as the one I showed before. So in principle, you can obtain from 1D Doppler ultrasound the similar information that you have on the canonical phonocardiogram signal. The recording principle is typical of the Doppler, physical Doppler sensors. So there is a transducer working between 1 and 4 megahertz. Uh, we must say that here that continuous wave Doppler and pulsed wave Doppler have different approach and different signals too, but we will not enter in the detail that much in this presentation. So the Doppler shift is related, as you can see in this picture, to the different velocity of the reflecting target, the speed of the sound in the tissue, and the angle that the incoming wave is with the target part of the body, in this case of the fetal heart. For this device, a piezoelectric crystal is used that can be used as an actuator and also as a sensor, because when it is excited by an electric alternating current, it operates generating the ultrasound, whereas it can be used as a sensor when it change the electrical parameters according to a vibration received in input in this case from the maternal abdomen, as the echo of the organs that have been invested by the waveform. This device was demonstrated to be not so useful in terms of perinatal outcomes in high-medium income countries, whereas it's still useful for low-medium income countries for midwives support, as in those places it's more complicated to have accessibility to better devices, more expensive and more complicated, like the ones that are used in high medium income countries. Important thing is that these devices, especially in the US, were sold as medical gadget, let me say, for the mothers that were willing to assess the condition of the baby or feel the heartbeat of the baby. And so there was an FDA warning on the use of this technology by unskilled people, like probably the largest part of the mothers and the parents in general, because it unnecessarily exposed the baby to energy of the ultrasound waves, which in principle can have also bad outcomes on the development of the baby. And it can create either a false sense of security or an unmotivated panic in an untrained personnel. So it must be careful used. Typically, the signal is analyzed in terms of autocorrelation function by using a window enclosing two bits. And so this limits the adoption of this technology to detect rapid decreases or increases of the fetal heart rate and to study heart rate variability in a very precise way, even though it is in any case used also for that reason, and other more sophisticated methods appears during the years. The same technology is used in clinical cardiotocography. Here you can see on the top trace the fetal heart rate acquired in the same, exactly in the same way, so 1D Doppler ultrasound. But here in the lowest part of the plot you can see the uterine contractions, which are recorded by means of another sensor, which is the so-called TOCO sensor. In terms of the fetal heart rate, the detection is the same that we mentioned before. Continuous and pulsed wave Doppler may be used for this reason, whereas uterine contractions are based on the application on the maternal abdomen of a sensor, which is a tocodynamometer, which is mainly a force sensor where the strain gauge internally detects the force that is applied on this central part of the sensor that is pressed on by means of elastic belts on the maternal belly. So the problems associated with this measurement is that are the body mass index and the gestational age. Because, for instance, for in early gestational age, the belly is small, and so it's difficult to detect the signals from the uterine contraction. And in case of maternal obesity, the body mass index is against a good detection of the signal. This signal of the uterine contraction can be also used to detect the intrauterine pressure. That, however, is better detected by means of a third sensor, which is an invasive intrauterine pressure catheter. The problem in this case is that it's invasive. Originally, they were exploiting an external sensor, but now the technology for producing pressure sensors evolved, so it is possible to have the sensor in the tip of the catheter. And these sensors are typically based on piezoresistive pressure sensors with some further conventional thick film resistors that are used for compensation and calibration in the probe. The research in this case also tried to study the best positioning of the ultrasound sensor. This is because typically the midwives try to find the best position for the ultrasound probe on the belly by exploiting the experience. But the baby can move during pregnancy in general when the baby is small, but also during delivery. And when the baby moves, you can see that the signal disappears somehow because it is difficult to detect in every moment the signal. So some researchers try to use multiple ultrasound probes in order to identify the best the position of the fetal heart, and so allow focusing the device on that specific part. For sure, it is possible to use these sensors even with the problem of the two bits together for the analysis of the fetal heart rate, so for the extraction of what we call the tachogram, which is a not evenly sampled sequence that usually transformed in an evenly sampled sequence by means of spline interpolation, typically at 4 Hz, and it represents the change of the heart rate during time. These techniques have been used to identify digital biomarkers for some specific conditions, such as placental insufficiency, perinatal hypoxia, congenital abnormalities, and so on. According to this, it is possible to predict the outcome and then, for instance, propose a cesarean section or other forms of surgical delivery in case of critical issues. But the problem is that it is difficult to exploit this kind of approaches in the clinical practice because the risk is very high, and gynecologists and obstetricians usually just follow the FIGO guidelines, which are conceived and approved worldwide for intrapartum monitoring. So even though the research developed some new indexes, they actually use in the clinical practice, for instance, based on heart rate variability patterns, the actual use in the clinical practice is still very limited. From 1D ultrasound, it is possible also to derive 2D ultrasound. Of course, on a conventional ultrasound machine, a cart-based one in the hospital, it is possible to have for the fetal monitoring the canonical pulsed wave Doppler or continuous wave Doppler, or the M-mode echocardiography, which is formally a 1D analysis of the signal. However, the ultrasound machines can be normally adopted for 2D image reconstruction of a slice of the volume under the probe that can be used for morphological analysis, study of the fetal growth, and identification of structural defects, even in the heart or large vessels. There are also improvements of the technologies in the field, such as, for instance, the development of the 3D ultrasound systems that are normally used to provide the image of the baby to the mother, but can also be used to detect some clinical features too. The so-called 4D ultrasound that adds a time dimension to these recordings, so it is possible to capture real-time videos, let me say, of the baby by sophisticated signal processing techniques, whereas the so-called 5D ultrasound technology is just an AI-based artificial enhancement of the facial features of the baby by adding, for instance, a shading, light that are of course unreal, colors that are of course unreal, in order to provide better resemblance of the fetus with the baby, but it's just for let me say for the parents, it's not a clinically relevant features typically. The 2D ultrasound can be very different according to the potential use. So you have handheld devices and that are not very expensive, and really expensive cart devices as the ones that are shown in this slide. Regardless of the high-end or low-end level of the ultrasound machine, the probes can be of different nature. So those that are, for instance, for the baby, for the echocardiography are the sector ones. The convex are more used for morphological analysis by gynecologists, and there are also other kinds of probe. From a technical perspective, the main difference is between the linearly scanned arrays, which are scanned one after where the piezoelectric crystals are scanned one by one, and the phased array, whereas in this case all the sensors, all the actuators are simultaneously excited, but with phase differences that are able to steer the ultrasound beam in order to cover a given sector, okay, behind the probe. Of course, this is relevant because knowing the Doppler principle, it is possible to understand that the frame rate is relevant in order to avoid aliasing effects that can disrupt the information that is recorded by the instrument. Another relevant fetal monitoring technology is electrohysterography. Electrohysterography tries to estimate uterine contractions by means of electrical signals recorded on the abdomen, so non-invasively. In this case, it can be for sure correlated to the intrauterine pressure, uh, resolving the limits of the intrauterine pressure catheter, which is the invasive nature of that device. The estimation of contraction frequency better than cardiotocography machines, because in that case the tocodynamometer had problems related to body mass index, movements of the baby, and so on, and also prediction of preterm birth by exploiting the information of conduction velocity. In this slide, you can see the fetal heart rate and the intrauterine pressure catheter signal, and what you obtain with the tocodynamometer and with the electrohysterographic signal. So as you can see, there is a quite good accordance between the intrauterine pressure catheter and the electrohysterographic signal, better than the tocodynamometer. Accordingly, the electrohysterographic signal has been studied from a signal processing perspective by considering different signal bandwidth ranging from 0.33 to 3.0 Hz that are split in three frequency bands. So the slow waves below 0.1 Hz and the fast waves that are split in low and high band. The first between 0.13 and 0.45 Hz, and the second from 0.8 to 3 Hz, which is the one that is more closely related to the uterine contraction. Of course, the number of electrodes and their position depends on the aim of the study. We can start from very simple system with a low number of electrodes to a system where the number of electrodes is higher, or even higher with the high density electrodes grids. In this case, the aim is that of studying the conduction velocity on the abdominal plane, because it was studied that it is higher in labor women compared to non-labor women. And so it is possible to predict by studying the conduction velocity of the EHG signal uh, potential preterm births. Fetal electrocardiography is mainly the most studied technique in terms of signal processing. It dates several, more than 1 century, because the first studies were very old, close to the discovery of ECG by Willem Einthoven. And it can be useful for the assessment of the fetal heart function, but also to extract biomarkers such as heart rate variability and so on, providing a monitoring technology which is low cost compared to the technologies based on the ultrasound devices and requiring less skills to be interpreted. Compared to CTG, it allows to achieve a bit-by-bit variability, with the pros that it is completely passive, so it enables long-term monitoring. Can be also coupled with electrohysterography to monitor uterine contraction, even by using the same electrodes. The problem in terms of the ECG is that on newborns and adults, you put the electrodes on the torso, typically, and you can obtain 12 lead ECG where the patterns can be analyzed clearly by exploiting the knowledge of the cardiologist that knows how the typical physiological and pathological patterns are represented in the ECG. So it is possible to conceive that the same happens for fetuses, but absolutely this is not true. And this is not true because on the baby it's not possible, on the fetus it's not possible to apply the electrodes directly in contact with the skin. So I go through quickly on these slides that just show the history of fetal ECG, which is quite old. Only 5 years after the first description of the ECG by Einthoven in 1901, Kramer used a combination of vaginal and abdominal electrodes and a string galvanometer as the one used by Einthoven to try to detect the fetal ECG that, as you can see, was not clearly visible in those traces. In the next 24, 30 years, nothing really happened. Some papers were presented with low success because recording technology was bad. Then, in 1930, started some studies where multiple pregnant women were tested for this kind of signal with a good success, and some studies on the best electrode positioning on the fetus for invasive exams appeared. However, the latest studies were affected by a problem because the bandwidth of the signal was limited between 30 and 100 Hz, so only the fetal QRS can be detected effectively. And so several studies presented in that period are critical and have been challenged when they were trying to show also P and T waves. In 1960, Hahn introduced the fetal scalp electrodes and changed the filtration between 8 and 50 Hz and introduced the synchronized averaging to improve the signal-to-noise ratio. This technique, the one of the fetal scalp electrode and the signal averaging, gave rise to the ST segment analyzer devices, the so-called STAN monitor that today is still used in its evolutions, that monitored the ratio between the amplitude of the fetal T wave and the amplitude of the fetal R wave, and the presence of biphasic ST segments that on adults are associated with ischemia. So it was supposed to be related also to hypoxia in fetuses. The STAN devices averages over 30 bits, and it provides better performance in terms of fetal intrapartum monitoring compared to other technologies. And for this reason, it has been used in the past, and it is also widespread used. However, the problem is that in this case you have to apply an electrode on the scalp, and the scalp electrode is screwed in the skin of the head of the baby. So it's an invasive procedure that is not exempt from risks compared to non-invasive recordings that are based on conventional ECG electrodes. Of course, the signal-to-noise ratio is different in the two cases, but the problem of invasive fetal ECG is mainly a problem of safety and the fact that it can be used only when membranes have been broken. Also, the advantages of these techniques during labor is questioned by some researchers. Lead position is also non-standard and vertex presentation is required. So fetal ECG with non-invasive approaches could be in principle better, but there is a critical issue that is represented by the accessibility of the measurand and by the vernix caseosa, which is a layer, waxy layer, that shields the electrical signals and hamper the detection on the maternal abdomen of the signal from the baby. Moreover, as this layer dissolves during pregnancy, also the propagation patterns between the baby and the abdomen, maternal abdomen change, making the fetal ECG morphology questionable after the 37 weeks of gestation. Again, as I stated before, there is a dependency on the position of the baby, on the placenta attachment, etc., that make this non-invasive approach quite critical to be applied. But several researchers demonstrated that it is possible, by means of signal processing techniques, to recover a signal that is very similar to the invasive one, but reducing the risks for the baby. There are several commercial devices that have been presented so far. All of them share the same approach of having a very small devices and a reduced number of electrodes in order to try to push this technology outside the hospital for telemonitoring of the baby. The main problem in this case, in all these cases, when you talk about non-invasive fetal ECG, is the significant overlap between the different electrophysiological signals that share the same space, and signal processing is needed in order to extract the relevant information from these signals. Other novel approaches in this field are based on the use of electrometers to detect the fetal ECG without any need for processing to separate the maternal and fetal contribution. However, this technology is not in the market, so it's still at research level. Just to close the presentation of these technologies, a more complicated approach is fetal magnetocardiography, where squid sensors are used and a magnetic shielded room is needed in order to suppress environmental electromagnetic noise. This technology is cumbersome because it's very expensive. It's not portable. It's also an active, a passive measurement, but the device is very complicated and huge, as you can see here. But the signal processing that is normally used to analyze this signal is the same that is typically used for fetal ECG, non-invasive fetal ECG, with the advantage of being resilient with the effect of and robust with respect to vernix caseosa influence. By means of this technique, it is possible also to extract, in principle, the fetal EEG with the so-called magnetoencephalogram, which is a measurement of the EEG activity of the baby during pregnancy. And there are studies working also on auditory responses and visual evoked responses by applying external sound or light, as you can see in this picture, on the maternal belly. However, as you can see, the technology is quite complicated and the benefit is limited from a clinical perspective, except for research. The last technology I'm sharing with you is non-invasive again, but it's near-infrared spectroscopy, which works in the field of near-infrared spectrum, so between 700 and 1000 nanometers, and consists of laser diodes putting light onto the belly and extracting the signal from backscattering and reflections with a detector, with a photodiode. In this case, the idea is that of studying the tissue oxygenation in a similar way that is exploited by pulse oximeters, but with a completely different technology, of course. And the research in the field is also aiming at developing not only studies by using conventional devices, but also studying new sensors and new technologies on animal models. So the research horizon, in my opinion, coming back to the same picture I showed before, is that of producing new devices that are wearable, because the future of these devices is telemedicine. Because in the hospital you have the possibility to use whatever technology you want, but at home you need very easy and low-cost technologies that can be used without very complex skills and can be telemonitored without large bandwidth requirements, that can be adopted in low medium income countries because they are low cost. The research requires better signal processing algorithms because, as you saw from this presentation, the largest part of signals are acquired non-invasively, so it's difficult to obtain the good quality signals. And there is also the need for research in artificial intelligence to improve signal quality and predict the outcome, because outcome prediction is one of the key challenges now, also for the adoption of this technology in the clinical practice from a different perspective. So no more as monitoring devices, just providing traces to the clinicians that must be human read by, but also providing a, a clinical support, clinical decision support system able to suggest to the clinician potential risks for the baby. All of this requires, of course, new technologies and new signal processing and artificial intelligence methods. And so I think that along with the technological aspects related to sensor, this is the key aspects of the research horizon in the field. So this was my last slide. I hope that it was interesting and clear. I apologize for being a couple of minutes out of time, but I will be happy to answer any question if there are questions. And I thank you again for your attention.
Thank you very much, Danilo, for this insightful presentation. Very interesting and like very clear and complete. So thank you very much.
So,
Also, yeah, you cover different topics going from also some historical perspective to modern system, which was very nice to see also the flow, like the evolution. So thank you a lot. And of course, if the audience has like any question, you can directly type in the chat here. So or you can also like raise your hand as you prefer. I can, because we have a couple of minutes more. Yeah, a couple of questions maybe. Yes,
I
please,
see a question.
Marta. Yes.
Hi, can you hear me?
Hello,
Yeah.
Yes, perfect. Thank you.
Okay, hello. First of all, thank you very much because it was a really very clear and complete presentation. I found it really, really interesting. And actually, my question is more related, I would say, to the very last sentence. So, what is your idea, your thoughts about the possible improvement that artificial intelligence can bring to the field? If these are the idea is simply to improve signal processing, or also, for example, a very simple example, reduce the number of electrodes in the approaches that have several of them, in order to try to get more information from less points, recording points. I don't know if you can comment a bit on this.
Yeah, thank you for this very important question, actually. Yeah, let me say that largest part of AI methods in the field were deployed not really to improve signal processing, but to increase the information extracted by this system. So to provide, let me say, decisions, support to the clinical decisions. So, for instance, prediction of the outcome, or prediction of specific condition in even in real time. For sure, there have been methods based on AI for the reduction of the dimensionality of the problem. So, for the reduction of the number of sensors, for the improvement of the quality, for the denoising. But the largest part of methods in the field are related, the largest part of the applications of AI in the field is related to the analysis of this signal to produce clinical information that can be exploited to take decisions, for instance, on a C-section, or on um, conditions or of well-being of the baby. And let me say that, in particular, the deep learning is now providing new insights also on the kind of signals that are there, because it is able, without any human extraction of features, to extract meaningful patterns from a lot of signals available. And so it's shedding a light on some specific peculiar aspects that were not known and were not seen by the researchers over the years. So, in my opinion, AI is mainly used for these reasons now in the field. In the spam workshop that I mentioned at the beginning, you see a lot of use of AI in this sense for the analysis of CTG signals, for instance, during labor.
Thank you very much. Thank you very much. Very interesting. Okay, let's see. Otherwise, have just a curiosity
Yeah.
about like actually the first part of the presentation, which you presented like the optical fiber sensor for monitoring, like in that case like quasi-distributed or distributed like sensing of the strain apply well, what is like the parameter which is monitor in that case, like which kind of sensor, like optical fiber sensor, they're explored for their research in that field.
Yeah, exactly. It's mainly based on the deformation. So sensors based on Bragg's, gratings of the fibers in order to detect the small changes. Consider that in that slide, I don't know if you need, I put it back on, but the sensor was conceived for phonocardiography, so it was detecting vibrations mainly. So yeah, it's a kind of ultra precise strain sensor uh, that, however, is not affected by electromagnetic interference. So um, the benefit is that one. The cons of that technology is
Mhm.
that it's very expensive, it's not really miniaturizable, and so it's difficult to use it outside the clinical settings. And in fact, to the best of my knowledge, there are no devices for the time being used in the clinical practice
Yeah. Okay.
exploiting that principle. So it's more related to the research niche. It's interesting because it can be in principle because of this immunity to other interferences. So it's a very sensitive sensor. Uh, and also the other important thing is that it's as the PCG is completely passive for
Yeah.
the
Okay.
baby. So it's safe even for continuous monitoring. However, it's not usable for ambulatory settings, for instance.
Sure. Okay, thank you. Mm, so of course this webinar will be recorded if also there are like we will make it like available on the website and YouTube. And okay, actually we're perfect in time. So
Good.
if there are if there are not other questions for the audience, we can like I can thank you again. Thank you very much, Danilo, for the very interesting
You're welcome.
presentation. Yeah, very
Thanks for the invitation.
insightful. Yeah. Thank you very much and have a great day ahead. Bye.
Thank
Thank
you,
you.
everybody. Bye bye.
Bye, bye, bye.